All right, let's talk about infectious diseases. And I feel like in a triple canopy jungle, hearing the rain hitting the leaves above me, so it kind of feels kind of normal. Okay, so infectious diseases kind of works fine in that area. Now, there's many kinds of infectious diseases, and believe it or not, you're going to encounter them all. Okay, when my professor first told me about rabies, he told us we would never see a case. Wrong. I got to see an active case of neurorabies. That was fascinating. I actually got to write it up in the MMR. Also got an active form of entoamoeba histolytica, which is brain amoeba. That was also a fascinating case. So when people tell you, well, you're not going to see some of these really rare ones, in Naples, you're going to see the rare crap. I don't know why, but I've never seen anything like it. I've worked in big hospitals before and not seen the stuff I've seen here. So you might be surprised. Now you can basically break it down into three major, and I've excluded one actually, which is the parasites. The parasites are, if you end up going into a mission or going overseas, I would highly recommend that you read about parasitic diseases, okay? Filariasis and things like that. So if you decide to do that. But it's a little bit above the scope of practice that we do here. And unless you're getting somebody from Africa or from different portions of South America, the parasitic components that you're going to be exposed to is pretty small. You are going to be exposed to a lot of bacterial, viral, and fungal diseases. If you look at bacterial diseases first, you can differentiate bacterial diseases based on the shell covering of the bacteria. Either you can call it a gram-negative or a gram-positive. Okay? And when you're looking at a bacteria, of course, it's a non-nuclear cytoplasm, so you don't have a DNA that's encapsulated in a nucleus like we are. Okay, instead, the actual strands are free inside the cytoplasm. Bacteria are pretty tough, though, and they divide by binary division, which makes them be pretty aggressive in their growth when they get into your system. And the other things that happens, too, is that the outer covering of the bacteria not only protect it, but also some portions of it can become endotoxins. When you begin to destroy these cells, it releases these different protein components, which sometimes are endotoxins, which are bad for us when it gets in our bloodstream. Okay. This is the gram-positive cell wall. Contains peptoglycans, amino acids, and of course your cell wall. What's interesting about the cell wall architecture is that you have now studies that can actually take a little sample of fluid, and if it's got a bacteria that's in high enough concentrations, it can actually identify that bacterial count and identify the organism based on its structure. So this has significantly improved microbiology. In the old days, you had to sit down and grow it for a long time and get you 2 to 3 days before you can get a result back. But some of these new studies are able to get some of this stuff back a little sooner. Not perfectly, but it's getting there. If you look at gram-positive infections, staph or strep pneumoniae is a polysaccharide capsule, and it can be serotyped based on the cell wall into Group A, Group B, and Group D. The Group A is what's called Streptococcus pyogenes, which is a pretty common infection. Okay, a lot of the Group B's are the OB infections, which will cause purpuric fever. Women used to die of it actually in pretty high amounts. In one hospital, before the advent of washing hands, mortality rate was almost 40 to 50% from physicians passing on strep to their patients, okay, which they used to call what's called purpuric fever. Group D is enterococcus, also known as urinary tract infections. They're pretty common. If you look at your strep, Group A strep, you can get what's called pharyngitis or strep throat. And the way you look at it is when you examine the patient, you'll see this pustular elements in the back and on the tonsils. Those are infectious, and they have high counts of bacteria in there. So if you put your fingers in their mouth and then you put your fingers in your mouth, guess what? You're going to get the same infection. Okay? Or you put it in your eye. So you got to be really careful. Okay? And one of the things that people make the mistake of all the time is they put their fingers in the person's mouth that has an active infection, and when you put in your laryngoscope and you can't identify this, you're either blind or you're not paying attention. Okay, or you're just sticking your blade in without it looking, which is another possibility. Okay, but after you take your finger out of the mouth, then what do is you grab the bag without taking your glove off. And now the bag is completely contaminated with a strep. So now you think you're fine, so you take your glove off, and now you've grabbed the bag is still full of infection, and then you put it on your eyes, and you've got a strep infection in your face. So you always sort of want to be very careful about where your hand goes after you insert it into somebody's mouth. The other thing that people are kind of, I've never understood this, but they don't really, I guess because most people don't understand it, is when you put your finger in somebody's mouth, which I'm not a real fan of, as you can tell what I'm telling you right now. It's necessary, it's part of our job sometimes. But there's other ways of actually opening people's mouths adequately, but you still have to know the scissor technique and everything else. Okay? But what I'm trying to tell you is once you put your fingers in that person's mouth, if that person has HIV or hepatitis or anything like that, and you know that ahead of time, you should put surgical gloves on. You're worth the extra $5, $6 it takes to put that glove on. The failure rate of a surgical glove is around maybe 0.01%. Okay, it's pretty low. The cheapo gloves that you get on the back of that box fail around 3 to 5%. And in some boxes, as high as 15%. And some people will even report as high as 30% once you put it against the teeth because you cut the cheapo non-latex glove. So, again, don't think just because you're wearing gloves that it's protecting you from skin contact. Always make sure that you wash your hands and keep them clean. That's actually more important. Now, strep A will form things like sinusitis, otitis, pneumonia, sepsis, endocarditis, meningitis, osteomyelitis, scarlet fever, and puerperal sepsis. So basically, it can attack almost every single organ system in your body. You can get skin infections like this, we would call impetigo. Okay, these are highly infectious. They burst, that have high amounts of bacterial count inside of it. So be careful if you're draining something like this that it doesn't get in your eyes. This is erysipelas, which is much more severe infections. Okay, usually are draining. Okay. Then you have what's called pyoderma gangrenosum, which is again highly infectious again if you're exposed to it. Sorry, that didn't come out very well. If you look at group A streptococcal infections, you have autoimmune diseases that are caused due to the cross-reactivity of the bacterial cell wall by the host system. So the immune system overreacts to it, and as a consequence, attacks the body anywhere this stuff sort of adheres to. So one place where you'd find that pretty well would be on the heart valves. Even a small little fragment of a bacterial wall that adheres to that valve will then be attacked by the immune system and basically begin to destroy the valve. If the bacterial cell wall that's lysed binds to glomerulus, it'll also attack the glomerulus, the immune system, and as a consequence you go into what's called post-streptococcal glomerulonephritis, okay, which actually begins to punch holes through the glomerular membrane, and you get spilling of proteins into the urine. This happens not when you're infected, but when the person is actually recuperating. And the way you see that this problem presents is usually the kid has been having a fever, and you start giving him antibiotics, and all of a sudden he seems to be getting better. And the next thing you see is that the kid's got puffy eyes, he's got peripheral edema forming, and all that's a sign of loss of protein in the urine. And when you check the creatinine, it's jumped up considerably, and that's what's from. Now, another one that's very nasty is staph. Staph aureus can actually be very easily treatable at times, but they can also be very resistant. Bacteria are learning from the environment they're exposed to try to survive against the antibiotic pressures that we're exposing them to. And it's becoming increasingly more of a battle as the antibiotics really are not that much different than they were 30, 40 years ago or 20 years ago, in the sense that we're not going to be making any more big classification systems right now. What do antibiotics come from? Do you know? Actually, they don't come from bacteria. They come from funguses. Okay? The normal host environment that bacteria live in is that they live under pressure from fungi. Okay? And the way fungus survive against bacteria, which is, they'd be very overwhelmed. They tend to be not as rapidly dividing, and they're not as aggressive. So how do they survive in a big bacterial world? And the answer is they survive by chemical weaponry. They release toxins in around them that kills the bacteria so they can continue to grow. Now, totally by accident, a physician named Fleming found penicillin. Okay, it was totally by accident. The way he actually discovered it was he had made a mistake. Actually, he started an experiment, and he left some bread, was actually his lunch, on the table, and left for the weekend instead of picking up himself. And the moldy bread grew, and it spilled into one of his dishes that was growing bacteria. And his observation skills, though, noticed that there was actually areas around the mold that died, that didn't have any bacteria. And from that, he made up the decision, well, there's got to be something in there that's causing the bacteria to die, and that's what he actually made it from. He made it from mold. That was first penicillin came from. Okay? What's even more interesting about Fleming is actually a story about him when he was a young boy, when I'm age around 14 or 15. I'll tell you the story, it's kind of interesting. That's how things fate, how it works out. At 15 years of age, he was a very poor man. He was not most likely going to go anywhere in life because he just didn't have any money. So he saw a kid that was drowning, or actually was dying in the moors because he had fallen into some bog. And this kid ran out and saved this guy's life, this kid's life. The kid was about 10 or 11 years old, pulled him out of the bog. Well, the father was so impressed, which was a rich person, that he decided to put Fleming through school, and made Fleming go through medical school, and eventually Fleming became a physician. What was interesting later on is that same kid grew up into an adult, and he became very sick and almost was in the process of dying from pneumonia. And Fleming was actually able to administer him for the second time in his life to save him penicillin, which saved his life. Who was a kid? Winston Churchill. So, things happen for a reason sometimes. Had he not done that, he would have died twice, and he would not have been able to keep the British out of trouble. So staph is one of those things that it can kill you pretty easily. It can even, some of its shell can actually, when exposed into your bloodstream, can cause very severe shock syndromes called TSS, which is toxic shock syndromes, an exotoxin. And you also sort of look for this. Sometimes usually that's embedded. The retained tampon in a woman is a very high risk of developing TSS. So if you have a young girl that comes in, you have to do a pelvic exam to make sure that that person has not had this problem. And you think, well, anesthesia, why do I really care? I'll tell you why. We had a patient that came in about a year and a half ago, young girl, 19 years old, and she was going to be brought to the operating room emergently for septic shock, and they said, well, she's got something that's in the belly and it's causing that she's got a perforated appendix or something like that. And when she came to my door, the first question I asked, did anybody do a pelvic exam? And everybody's looking at me like, why would we do that? And I said, I'm not taking this girl back to the operating room until you do that. So the surgeon did a pelvic exam, and guess what he found? He found a retained tampon, which contained high amounts of staph, which was giving her TSS. She did not require surgery. If we put her to sleep, she would have hemodynamically fallen apart on us and might have died. And about 3 years ago, that same scenario happened, but that person got into the operating room and actually that person died intraoperatively. Okay, so don't put people in the operating room that's in shock unless you absolutely know the diagnosis. Exploratory surgery is a waste of time 99% of the time. And why do I say that? Because it only takes a 1 centimeter foci to kill you of bacteria if you have TSS. Okay, so it doesn't take much. So I always look on the other places first. The other place where I look for TSS or shock like that is in the teeth. Open the person's mouth, and you'd be surprised how many people have abscesses in their mouth. And a dentist can take care of it faster than you can. You don't need surgical anesthesia for that. You just need local anesthesia. Staph depends on the virulence. and some of them are actually, the cell membrane causes toxic shock, can cause exfoliation, and some of these toxins can actually, of course, cause the person to get nauseous and vomit, and of course, go into profound shock. You have also MRSA. MRSA is a very big problem, especially in the United States. The reason it's such a problem is because you've got so much colonization in this area. It's usually from patients that are in prolonged hospital stays, because what ends up happening is the normal staph that's on your skin gets eroded away, and then you have the methicillin-resistant stuff that's left around. Usually it's seen in patients over the age of 65, and if you have invasive procedures or have any kind of surgical drains, these bacteria seem to do well in open wounds. They're also very hardy in the sense of diabetic patients. They seem to survive and do well in those kind of situations. And they tend to show up when you have multiple broad-spectrum antibiotics being administered to the patient. It's also been found in inpatient and neonatal and surgical ICUs, and especially in burn units. Now, how do we really get rid of this problem? The answer is it has to be with providers. You have to basically prevent the providers from passing on the MRSA from one patient to the next. It's really easy, okay? And there's so much of the population that has MRSA that it's becoming a bigger issue. In Europe, one of the countries, which was, I think, Norway, decided that it was not going to have any more MRSA. And they actually got rid of it in 3 years. They have no more MRSA in any of their hospitals. Wow. How did they do it? And the answer is they went after the nursing homes, and they went after anybody who had MRSA, and they went into isolation. And they were militant about having people wash their hands in and out of the rooms. Not just wearing protection, but actually washing hands. And within 3 years, they eliminated it. Okay? So they're down to almost no cases or very few cases. Versus in the United States right now, you're looking at MRSA rates of close to 10% of all the infections that you see in the hospital. That's pretty bad. And these are not easy to treat. You can form, of course, staph forms carbuncles, okay? And when you drain fluid from one of these, it's more of a caseous material. You can develop what's called paronychia, infections like this in the skin. If you see somebody come in like this, or you have this, you're infectious. You need to be treated for this before you come into clinical work. This can happen pretty easily if you put your finger in somebody's mouth that has an infection. Then you can get what's called staphylococcal scalded skin syndrome. These people act like burn patients, and it can be a real problem. Let's go on to our gram-negatives. I didn't even touch the surface of VRSA, which is vancomycin-resistant Staph aureus, or those are really nasty bugs. So let's go on to the gram-negatives. The gram-negatives tend to live in more of an anaerobic environments. It means they don't like oxygen. Okay, so where you find gram-positives, they tend to be more aerobic, so they tend to be on your skin. Okay, they're exposed to the atmosphere. Gram-negatives, on the whole, tend to like just low oxygen levels, so they're found in your GI tract more. So E. coli is a classic example of a gram-negative bacteria. Now, there's differences in the way the cell wall is made, and I'm not going to ask you too much on that. Just know that there's a difference between the cell wall. Gram-negative infections can, be either different kinds of problems in the sense that you can form warm or cold shock from it. You can activate the immune system. You can also activate the complement activation. So you can get all sorts of clotting, hypercoagulation situations. And you can also get severe shock syndromes from the actual mediators that are released by the bacteria and also by the cells that try to fight off this bacteria. If the normal classic gram-negative bacteria that people talk about is E. coli. And E. coli is actually pretty friendly most of the time because it's a normal GI flora. But not all E. coli is made up the same. Some E. coli can actually proliferate very aggressively and cause urinary tract infections and cause very severe diarrheal diseases. And some of them can actually release endotoxins into you that will kill you very easily. Okay. Gram-negative bacteria here is also, this one's Salmonella. Salmonella typhi is also known as typhoid fever. It used to kill a lot of people. It's a life-threatening infection, and it's usually passed on via fecal-oral route. Okay, so there was a famous lady in the 1900s, early 1900s, known as Typhoid Mary. Typhoid Mary finally got arrested and put in jail and would not be allowed to leave jail, because every time they allowed her to leave jail, she had a whole slew of victims that would follow. She was partly a nanny, then became a cook. So you can imagine she wasn't very good about washing her hands, and every time she came into working with a family, everybody got sick, and a lot of people died in the family where she took care of them. Or if when she was a cook, a lot of people fell sick, and when she cooked. So not something you want. She was a carrier, and some people are carriers and tolerate it without problems. But most of us, if we get this kind of salmonella infection, we get pretty sick. Okay? There's many different kinds of things that you can try. There's different things you can do to prevent getting salmonella, which is mostly cooking things properly. And where you see a lot of salmonella nowadays is in chicken. Okay, so if you leave chicken out for too much time, it easily grows bacteria like this and becomes very infectious. Then you have shigellosis or shigella, which is usually found in shellfish. I'm not a fan of eating raw oysters for one of these reasons. The other thing you also get from raw oysters is oysters are bottom feeders, and what they do is they clean the water, and anything that's dirty in the water, they absorb into them. So hepatitis C, hepatitis A, whatever you think, whatever goes into the water from somebody defecating in the water will then go through the oyster, and then you'll eat it. Isn't that wonderful? Okay, so you got to make sure that your supply of oysters is in a non-area of human droppings. Okay, because then you'll get bad diseases like Shigella. Okay, and it gives you dysentery. Most of the third world countries, shellfish is never not cooked. It's always cooked. I was actually surprised when I came to the States when people said, you eat raw oysters. And I go, really? The oysters I always ate, we always cooked them to the point that they were rubbery and you could throw them against the wall and they'd bounce back and hit you. So, this is another thing that'll kill you pretty quickly, Vibrio cholera. Okay? Cholera was a great finding in the sense of for the first sewage system that was put in the world was in London. Okay, cholera was killing lots of people due to the actual water sources were contaminated because it's a fecal-oral route spread. And one of the physicians, I can't remember the guy's name right now, starts with an S, I think. Anyways, he figured out that cholera was coming from one single well in London. And he did a great epidemiological work to figure that out. And after that, they decided, well, let's separate our sewage from our normal water. And they actually began to build the great London sewage system. And if you ever go into the London sewage system, it's very interesting. It's all made out of brick. And it's handmade brick. And they actually put it together. It's made huge tunnels of the stuff. And they were able to divert the sewage away. And in those days, the treatment options was dump it into the local river. So the Thames didn't smell very well, as you can imagine, which is where London's at. But it was very effective about moving the feces and the urine downstream away from the city. And the cholera epidemic almost stopped after that. Okay, then they had very few counts of cholera after they finished the sewage system. That has actually done more for health than any physician ever has. It's just the simple idea of sewage and separating it. Now, this is still a majority of third world countries. Okay, this is actually where the kids play. And what you see in the morning is that everybody throws, they usually have, they don't have any toilets, they have a pan in the house, and they defecate in the pan, and they throw the feces and the urine into the water. And then the water, when it rains heavily, it takes all the stool, moves it downstream. It works really well when it's heavy rain, but otherwise, if you have a bunch of kids around it and they play with it, of course, if you see a standing pond of water and you're a kid, what are you going to do on it? going to put a boat on it. You're going to play with your soldiers on it. You're going to do something close to the water, which is then, of course, going to give you diarrheal diseases, which is the leading cause of death in children under the age of 10. Now, you can also have some really rare, very bad gram-negative infections like Pseudomonas. Pseudomonas is like this. You see this color? This is a hematoma. This is what Pseudomonas looks like in high concentrations. It actually turns the skin and the tissue green. If you see if somebody's coughing up sputum that's green, that's what they have, Pseudomonas, which is, it loves anything that's wet. And the reason that people get infections of their toe like this is because they have their feet in socks and it's kept warm and moist. So the Pseudomonas tends to grow there very effectively. Where Pseudomonas is found almost universally is every single hospital. If you take a swab and you put it down the drain, what do you have at the bottom of the drain? Okay, how many people know anything about plumbing? Okay, some people do. Okay, at the bottom of every single sink that you see in your house, in a hospital, anywhere, okay, you have this U-shaped tube at the bottom. That U-shaped tube holds water inside of it. The reason that water's there is to prevent sewer gas from coming back up through your sink, okay? But that water is a perfect medium for bacteria, and Pseudomonas loves it there. So if you wash your hands and you have Pseudomonas on your hands, Pseudomonas goes into the drain and is happily living there, waiting for the next amount of skins that comes down there to be fed. So it's pretty much impossible to get rid of Pseudomonas in the hospital because of that, because it lives in all the sinks. Then this is what you can have. You can have Pseudomonas infections of the skin of the burn patients. Okay, you can see it's actually turning green. I've seen it worse than this, and it's not very good. The outcomes tend not to be good. Then you have some things called form-forming anaerobes. These are really difficult to get rid of. This is why we actually heat and compress, which means we pressurize the system to clean our instruments. Okay? When you actually cut into somebody and you use a scalpel and you reuse it, unless you pressurize it, you can't get rid of C. Clostridium perfringens, which causes gas gangrene. Okay? In the old days, when the surgical instruments would just be boiled, people would still develop gas gangrene. The next patient that got exposed to it, which of course was the main reason why people were amputating in the old days, was uncontrolled infection. So they would amputate the leg, and they wouldn't waste their instruments. They would just re-sterilize them and think everything's fine. But unless you compress it, you won't be able to kill the spores. So what you do the next incision, you put the infection back into the next patient. So not something you want to see. Where you also see Clostridium perfringens is you'll see it in food poisoning. Although I don't know how you could get food poisoning with this stuff, because if you have to be obviously not paying attention. What this does is, if you get this stuff in a can, is that the can gets bubbled. Okay? If you see that the grocery store is selling it to you for a rebate, don't buy it. It's not worth it. You're going to die. Okay? You know, I just understood that. You know, it's like these cans are on sale. It's like, yeah, they're all bubbled. It's like, what are you thinking? I saw that about a week ago. I looked at my wife and says, who would buy this? She says, I don't know. She says, it's cheap. It's like 10 cents per can. I said, yeah, it's equivalent to death. I just wanted to open it up and see how much gas came out of it. This is what happens with Clostridium tetani. Okay, this is still endemic in some countries. India has a very high incidence of Clostridium tetani. It is a CNS toxin which causes tetanus like this. And why is it so endemic in India? Do you know? The way they stop bleeding after placental delivery is on the baby is they cut the umbilical cord and they take dirt on the ground and wrap it on the umbilicus. And that's not a really good idea. The kid's got active blood going through there, and dirt's full of Clostridium tetani, and the kids get tetanus. Not a good thing. So they're trying to retrain people not to do that. Now, there's a reason they did it, and actually it makes sense. Some of the soil that's really red has what kind of content of what in it? not iron. It says iron too, but it's got another, very close to it, another cation. Calcium. Calcium is very helpful in stopping bleeding. Okay, so people were noticing that if they did that to their kids, the bleeding would stop right away and it would help. That's true, but the problem is that the soil is full of Clostridium tetani, which then the kid would get tetanus. Tetanus in the third world countries are still a big issue, and that's why you need to get your tetanus shots. And tetanus is still present even in our environment here in Florida. So you got to be very careful, make sure that you're kept up to date. Okay? The way we treat this is with high-dose Valium. Okay? Sometimes in the United States you get intubated for this, but you don't fully recover after this. You still have a certain degree of injury, but you still can recover, but not fully. Then you have botulinum. Which is kind of interesting. We medically give this. We don't give the bacteria, okay? We give the botulism toxin. Somebody decided to actually, Chinese were selling C. botulinum, and somebody decided to buy it, and that's not the same thing as the botulism toxin. So they injected themselves with it and get themselves botulism poisoning, and they died. So not good. The actual toxin is a neurotoxin and prevents presynaptic release of acetylcholine. So it gives you a very intense paralysis. So if you're doing this to your face or something like that, it'll make your muscles in your face not to be able to contract. What actually very much amazes me is how uncontrolled this is. There's actually Botox parties where people do it at home with their friends. And there's actually been 1,382 reported deaths from Botox injections since the advent of this. So that's a bad thing to die from, you know. And they actually had two plastic surgeons die from this about a year ago, or 2 years ago now. They called 911, but all they heard was at the other end of it, and by the time they got the paramedics there, they're both dead. Spirochetes, or a form of which is Treponema pallidum, is a syphilis. Syphilis is non-painful, so when you see this in an individual, you think this would be very painful chancre, which apparently it's not. But unfortunately, what that means is that this is the primary chancre, and if you don't treat it appropriately, it goes on to neurosyphilis, which is a big problem. This is this phase 2. This is mucocutaneous lesions. These people are highly infectious. The contact alone will get you that disease, so you sort of want to avoid these people. They get mucocutaneous lesions, lymphadenopathy, and splenomegaly. And then you go into the tertiary syphilis, where you get destruction of the central nervous system, as well as you get the aortic dissections and aortic dilations. It's a really big issue. Then you have a little bit more rare diseases, more rare spirochetes called Borrelia burgdorferi, also known as Lyme's disease. I love that name, Borrelia burgdorferi. It's actually somebody's name, believe it or not, Burgdorferi. It causes Lyme's disease. It's found now a lot more in the northeast. With the advent of non-hunting, the actual deer have been taken over. Okay, and as a consequence, the Lyme disease is actually beginning to spread. And people are actually beginning to pay big money for people to kill the deer just to get rid of them so that Lyme disease stays under control. Lyme disease, of course, is not part of the deer, but it's a part of the deer tick that's on the deer. And these deer tick don't really care if you're not a deer. If you're walking around or you're hunting and you kill the deer and the tick decides to jump off on you and bite you, he'll give you Borrelia burgdorferi just fine. Okay? And you get this kind of nice, beautiful target lesion. Okay? And you can't really miss it in the sense that, you know, if you've been in the woods recently and you all of a sudden felt you got a bite or something, or even if you don't feel like you got a bite, but you started getting fevers, not feeling well, you get this like weird arthritis that attacks almost every single joint, and you get migraine headache, and you get encephalitis, and that's an indication that you have Borrelia. Then you have the mycobacterial walls. They're also different. In Mycobacterium tuberculosis is an obligate aerobe. These guys tend to love oxygen, and TB is most of the time asymptomatic, and they only pick it up by PPD test. If you wait too long, it'll start eroding into your upper portion of your lung and start destroying the lung. Okay, usually found in the upper portion of the lung because that's the area of the lung that has the most oxygen levels. Okay, remember, there's no perfusion to that area as much, so oxygen uptake is less. So the highest oxygen level, and which makes the reason that the TB is found in the upper apex of the lung. Now, the treatment in the old days, you'll find it here, is that you still see people in their 80s here who have had TB when they were kids, and the only treatment they had in those days was not antibiotics. They would actually go in with a trocar and penetrate the upper apex of the lung, jam it like a needle, jam it about 10 times, and then they would put in the chest tube and let that upper lobe completely collapse. Okay, so the upper lobe's gone on those patients. They have no upper lobe. Okay, and that decreases their exercise tolerance, but otherwise it doesn't kill them, and the TB effectively dies because of it has no more oxygen. Interesting treatment, to say the least. We might go back to that because some of these mycobacteria are becoming heavily resistant to the antibiotics. Some of the stuff that's coming out of Mexico is triple antibiotic resistant. Bad stuff. So hopefully be very careful when you're taking care of people. They're coughing and you don't have any, you have a high index of suspicion. You make sure that you're wearing your duck mask. Quack, quack. You got to look cute, you know. Then this is one of my favorite diseases, all the way described back in the Bible, which is Mycobacterium leprae, okay, leprosy. Leprosy is actually found in the United States in high amounts in Louisiana, okay, and actually is being studied actively in that area still to this day. It's also known as Hansen's disease, okay. Leprosy comes from what animal? Armadillos. So if you're an armadillo fan and you love to eat them, I highly recommend you don't. Especially one of the slow ones. Okay? The slow ones means that he could have leprosy. Okay? You know the old saying of why does the chicken cross the road? Just to show the armadillo that can be done. How many dead armadillos you've seen on the side of the road, right? So don't mess with dead armadillos. In other words, if you're up in that area, there's not so many. I haven't heard too much leprosy in the armadillos down in this area, but I know in Louisiana they have a high percentage of the armadillos have leprosy. Now, leprosy is treatable. It will respond to antibiotics. It just takes a long time. And if it's untreatable, this is what used to happen, and it still happens in some third world countries where they don't have the treatment options, and it literally will eat away the digits. It is a highly infectious disease, so they were right in the old days to isolate these individuals and put them not with the rest of the population. Okay? If you had leprosy and you walked into town without designating that you had leprosy, you would be killed, just to try to prevent you from spreading the infection. You also have molds, which are mycotic infections or yeast. Okay? The molds tend to be filamentous, and versus the yeast grow as ovoid or spherical. Yeast infections are usually not something a human being has to encounter most of the time unless you're immunosuppressed or on multiple antibiotics. So normal bacteria will actually overwhelm most yeast and most molds most of the time. Okay, but you can get molds that are pretty nasty and it can get into the skin, and especially in somebody who's immunosuppressed. Cancer patients are at high risk for those. Let's look at our different mycotic infections. And I've seen some of these. These are really nasty, and we actually have to take these people to the operating room and basically cut away the skin for their survival. And this is, so you can imagine, it's going to be very disfiguring when you do this. If you have what's called blastomyces dermatitis, it can have up to pulmonary involvement where you get pneumonia from it, and you can get significant orthopedic deformities, and you can see the infection. The only way to cure this is really to cut away a good portion of it and then treat it with antifungals. You can see how severe the disease can become. Okay, you can see it even after repair, you still see the infection still spreading. This is not a good outcome, as you can imagine. Then you have coccidioides imitans, okay, which is found as pneumonias, and it also causes meningitis. Where is coccidioides found mostly? And the answer is the Midwest and the Southeast. You tend not to see it here in Florida as much. This is what coccidioides imitans looks like. It basically destroys soft tissue, and we'll get into the lungs and get into the brain. Now, the way it gets into the brain is usually directly through the wall of the cribriform plate. Actually, it travels up the nose and then goes up into the brain that way. And that has a very, very bad outcome. Then you have what's called histoplasmosis capsulatum, which is mostly going into the lungs. People can get very, very sick with this, and it's, again, another one that's usually immunosuppressed patients that hate HIV. We learned all these things from because HIV, it became much more frequent, and they're rare. You wouldn't see this very often for most of the general population. Then you have mycoplasma pneumoniae, which have no cell wall, and they're atypical community-acquired pneumonia. Most mycoplasma doesn't kill you, but it will significantly impair your ability to breathe at times, and unless appropriately treated, sometimes can overwhelm you if you're immunosuppressed. You also have what's called rickettsial diseases. Rickettsial diseases like Rocky Mountain spotted fever usually come from ticks that bite you first, and these are rickettsias, which is a kind of parasite that's inside that. It's not the actual tick that causes it, it's the actual parasite inside the tick. And it causes a severe thrombocytopenia, and you can get pretty sick with Rocky Mountain spotted fever. The reason they call it spotted fever is, you see this? It looks like you got spots all over you, and the spots are from the capillaries bursting in your skin. So it's not a healthy thing to have. Imagine the rest of the organ systems, which are inside your body, have the same issue. So you got hemorrhaging into your lungs, hemorrhaging into your kidneys. A lot of bad things happen. It's storming outside. Then you have what's called Coxiella burnetii, Q fever. It's airborne from livestock. Hepatosplenomegaly is found in most patients, and normal LFTs. Then we'll talk about viruses really quick. The most common virus that we tend to encounter is hepatitis. That's one we are most concerned about because it's very high risk for getting it. It's actually highly infectious. The way a virus works basically is it enters into your cell. It basically uses your own DNA, usually, to make new cells of it, new viral sheets of it, and then it encapsulates its DNA or, RNA or DNA back into the capsule, and then this releases into the bloodstream so it can infect more cells. Okay? There's many kinds of viruses. There's there's DNA and RNA viruses, and they're pretty smart little systems considering they're not really considered living because they don't have any organelles and they don't have any what can I say? They don't produce anything. All they do is they hijack the cell to be able to survive. So a virus by itself can't survive. It needs a host. So it's a completely parasitic disease process. Now, viral viruses can be very lethal because they attack all cells in the body, and where the damage occurs is not from them going into the cell, it's when they burst out of the cell. They get lots of lysis of cells. The other thing that happens too is that if it gets into your DNA, what happens to your DNA? Your DNA doesn't work properly. Okay? A lot of the leukemias that are thought of are felt to be due to an initiation event from a virus. Okay? Could be CMV, things like that attack the DNA, and as a consequence, that DNA that would normally be protected and not have any kind of transcription error develops a transcription error, and now the person develops increased cell proliferation of a certain cell line. Influenza is one of those things that kill you pretty easily. You can get, of course, the flu. Rhinovirus, which is a common cold. Adenovirus, which can affect what's called epidemic keratoconjunctivitis. I'll show you pictures of that. RSV, parainfluenza virus, and HPV, which can be a real issue in developing warts, especially on your vocal cords. We used to burn these off without people wearing masks in the room. You can't do that anymore. Okay? You shouldn't do that. It made absolutely no sense to be breathing in that smoke. I never understood that. When I used to work in ENT, when they used to do a lot of laser, you could see the smoke coming out of the area after they're firing up warts. And we're like, this is not smart. And some of the guys would take their mask and push it down so they had their nose exposed. And of course, they would get warts inside their cords. So just because you're flaming it with laser doesn't mean that it doesn't kill the virus. It's that tough. So herpetic infections can be a problem. You can have type 1, which is oral, and then causes ocular and CNS spread. Okay? And these lesions are usually painful at times, so it can be an issue. If you have type 2, that's a genital herpes. Most of the time, what we're exposed to, of course, is type 1. But it can go from one area to the next. If you look at herpetic infections, varicella zoster is a form of herpetic infection. It's also known as chickenpox, and if you wait too long enough, it becomes shingles. Shingles is a reactivation of the varicella zoster after the immune system drops off, and you get this distribution pattern that follows the nerve, because the actual zoster, where it does is it hides in your nerve sheath, okay, and it stays there, quiescent, as long as your immune system's intact. So usually we'll see chickenpox recur in the age of 65, 70, and as reactivated shingles, which is very, very painful. Some people even recommend putting epidurals in these people to control the pain. There's different arguments about what to do with it. There's other forms of herpetic infections, or things like cytomegalovirus and Epstein-Barr virus. Okay? Cytomegalovirus is ubiquitous. It's almost all the population has it. To find somebody that's not CMV positive in the adult is actually hard. It's like 80% of the population is CMV negative, CMV positive. If you look at Epstein-Barr virus, it's about 90% of people have been exposed to it, and it can cause infections of mononucleosis in some. EBV virus is also associated with other things. It's also X-linked lymphoproliferative diseases, cancers like nasopharyngeal cancer and Burkitt's lymphoma. And it's also Epstein-Barr virus has been associated with in AIDS patients who are developing what's called oral hairy leukoplakia, which is a rare cancer. It's a pre-cancer of the tongue. And you get also lymphoid interstitial pneumonitis and non-Hodgkin's lymphoma. This is the big culprit that happened back in the early 80s. When I went to medical school, they wouldn't allow me into medical school until I signed a document. It was rather interesting. On that document at the time was nobody knew what was causing HIV. And on the document said that we would basically make the university free of any concern that if we get HIV, that it was our responsibility. So, and we had to sign on the dotted line if we wanted to go to medical school. So if we got exposed to HIV and died from it, it was tough luck. And really at that time, nobody knew what was causing it. So you had to be a little bit nuts to go to medical school at that point. A lot of us did anyways. We figured something would be up, and they'd figured it out. Within about 2 years of that, then they figured out it was HIV, it was a virus that was causing it. Okay? But it was actually a pretty scary time, and nobody really knew how to deal with it. When I first came out of training, I went to anesthesia school. Everybody was wearing gloves about 12, 13 hours a day. And these were all latex gloves, so a lot of us got latex sensitized and latex allergic because of it. We found later on that HIV is actually fairly rough, very difficult to get via oral contact. It's mostly from blood contact that you get it, and sexual contact. So it is a little bit difficult to get it. You can't really get it from somebody by drinking their glass of water or anything like that. It's not going to happen. Not that I recommend it. There's other things that you can get from people, which is like hepatitis, you will definitely get if you share glasses with them. But HIV is a little bit more difficult to get, thank goodness. The other thing that HIV has also changed dramatically from what I learned, what I trained. The first HIV was extremely, extremely lethal. Okay, it was killing people, and it mutated. It mutated into a less virulent strand. Okay, so the HIV that we're dealing with nowadays has a lower mortality rate than what was first diagnosed 20 years ago. Okay, now where did HIV come from? You guys know where it came from? Right. It actually came out of the jungles of Congo from a virus called it's called simian immunodeficiency virus. Okay, it most likely came from a hunter who went into the jungle, killed a monkey, broke skin, got in contact with the skin when he skinned the animal, got into his bloodstream, and then he passed it on. And pretty much, we know it's from monkeys. Unfortunately, now you got 30 million people, or a lot more than that are infected with this stuff. So, if you look at cellular physiology of HIV, it's an interesting virus, okay, because when it infects you, okay, it sends in RNA. Okay, so it actually it's not DNA, it's RNA. And how does it get into your DNA, though, if it's RNA? It has what's called an enzyme called reverse transcriptase. The reverse transcriptase reads the RNA and backwards and is able to produce DNA strands out of it, which then that DNA gets embedded into your DNA, and that is what produces the viral coating. What's interesting about this virus is what makes it really interesting in the sense of studying it is that because it embeds into your DNA, it alters its protein coat every time it enters a new host, which is a real pain for us because guess what? You can't find an antibody to knock it out. You can't develop a vaccine to kill it because every time you get a new strand, you get a new protein coat. Okay, so each one actually comes from a different. Now, what's interesting, though, is that because it comes from the same protein coat, you know who the infector is. Okay, if you have a virus and everybody has the same viral coating, guess what? It came from the original infected person that gave it to you. Okay, so you can actually track the coding will tell you where it initiated, what person it came from. The first HIV, when it first started in the United States, was actually from an the big spreader of it was an airline steward, and he passed it on to about 800 people is what I think has been described. And from there it spread even faster. So perfect medium. He was at a new place every other day from his different flights, and he was having unprotected sex with other males. So that spread the virus very, very rapidly, and pretty much in all the major cities in the United States. So it's a pretty bad way of spreading it. HIV causes eventually develop AIDS. So AIDS is really not the virus. AIDS is the result of AIDS of the virus. If you have somebody that has HIV positive, doesn't mean that they have AIDS yet. AIDS requires that you have profound immunosuppression, which leads to life-threatening opportunistic infections, things like Kaposi sarcoma. Contact is still by sexual transmission, bloodborne, or post-exposure AZT sometimes will be used to prevent transmission. It decreases the rate of seroconversion. And the way you pick up on this is by ELISA studies, and of course there's other new studies that are being used to be more effective in diagnosing HIV. This is what Kaposi sarcoma looks like. Treatment is the antiretrovirals. I'm not going to go into it. There's a whole slew of ways of treating this now, which it's above my level of understanding, so I'm not going to go into it. Just know if you start seeing people on nucleoside analogs like adenosine or Zalcid, all these names, which is AZT, and protease inhibitors, then you know that person has HIV. And a lot of people won't tell you that they have HIV positive. But if you look at their medications that they're on, they're all antiretrovirals, and that indicates to you that the person has HIV. Because trust me, unless you ask, and even when you ask, they're not going to tell you. okay, even though it may be a risk for you. Ultimately, you have to take universal precautions, and if you have been exposed to bodily fluids, then you need to consider doing prophylactic antiretrovirals. It's recommended for high-risk needle sticks. Usually the hollow bore needles are much more risk, of course. And if you have intact skin, even though you get blood directly on you, it's not going to get you infected. Just wash your hands right away and make sure that you don't have any breaks in your skin. So, and it's not even if you have exposure to urine, you don't have to worry about it. It's never been diagnosed, never been a transmission of urine, which is pretty apparently still sterile. Now you have other forms of viral problems that can attack the heart, which is called myocarditis. Viruses can do that. The number one of that was adenovirus. Cytomegalovirus also attacks the heart as well, but mostly it's adenovirus. There's also, of course, your protozoa, which we talked about before, Chagas disease, Trypanosome cruzi. This is our retidiform bug, which the parasite inside of it, which is Trypanosome cruzi. And then you have things like drug-induced problems that can attack the heart, doxorubicin, and you also have autoimmune processes. If you look at nosocomial infections, they're a big problem in the sense of surgical infections, IV access, urinary catheters. Anesthesia equipment is very rarely the reason for nosocomial infection. If you look at the actual incidence of us inducing a pneumonia, it's almost zero. There's never been anything that can grow in the barreline. The barreline is so toxic that everything dies in it. Okay? That doesn't mean that you shouldn't be protective of it, in the sense that you should not, let somebody who has active TB breathe into your ventilator. That's why you have filters. But the idea of having to change out your barreline every time you do a case is not necessary. It's just you can't really transmit infection from the machine itself. Now, if your circuit was dirty, that's different. So we actually make disposable circuits. Some people still argue that that's not even necessary either. I tend to disagree because I think it's better to just clean out the actual. I remember the old days when we used to take the black tubing, which is what we had, and we used to dump it in the sink, wash it, dry it, and then go and grab the next one. I mean, I don't know. I don't want to be breathing into somebody else's tube that's got mucus in it and it's really not properly cleaned. I think that's not really smart. Now you'll still encounter that sometimes in the major cities because the major cities have so much expense on cost of getting rid of stuff. So sometimes you'll still see those kind of systems in place. But most of the time you don't here anymore. Sepsis and septic shock. There's many different pathogens that are causing sepsis or septic shock. It could be actual truly intact bacteria that get in your bloodstream, but there's also, of course, endotoxins that can be released. This leads to release of cytokines,